Essentially, the pharmacokinetic profile of the different esters is based on the principle of mass balance, and that's the rate of change in serum testosterone level is equal to the rate of secretion and absorption minus the rate of elimination. Now, the reason I mentioned secretion is due to the use of HCG in some treatment regimes, which has been shown to preserve the function of the secretion of intratesticular testosterone in patients, which theoretically could facilitate the use of the minimum effective dose to yield the best outcome with the lowest level of negative treatment effects, or more commonly known as side effects. So, all medications will have their own peak plasma concentration, or Cmax, and elimination rate constant, and therefore their own elimination half-life that is specific to them. This is also true of testosterone and its different preparations, from different ester injectable preparations to gels, creams, and more. Now, in pharmacokinetics, there will be a point when the amount of drug consumed will reach a point of equilibrium with the amount of drug excreted, and this is known as reaching or achieving steady state. The achievement of steady state is pretty much the goal of TRT and most ongoing therapies, as this is otherwise known as normalization. So, getting back to why we need an ester, bearing in mind what we've just learnt about the drug half-lives, testosterone on its own, or we call that testosterone suspension, so simply the testosterone molecule suspended in water, has a half-life of around 2 to 4 hours. In other words, it's metabolized really quickly. Now, if we utilize testosterone suspension for TRT, we'd have to inject our replacement therapy between 3 and 8 times a day, and this just really is not practical. So the function of esterification, or the addition of that ester to the testosterone molecule, is to allow for an extension of the time the molecule is active in our body, or sometimes referred to as the time being systemically active.